Good morning, everyone. Thank you for joining PHCA for today's webinar, Renegotiating Community Health Choices Contracts. I'm Zane Barrick with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded today and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for PHCA members. The credits will be uploaded to NAB within the next week for those who have provided us with a unique NAB number. At the conclusion of today's webinar, a survey will be launched, which is different than we've done in the past. Your feedback is important to us and our speakers, so please take a moment to complete this survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. This webinar will be presented by Cynthia Haines, Principal with Post Schell. The Community Health Choices program in the Southwest will reach the end of the initial term of the CHC contract and the continuity period at the end of this year. Facilities in the counties affected by Phase 2 and Phase 3 will reach this milestone over the next 18 months. This webinar today will allow you to learn from the initial term and help you to identify possible renegotiation points and the best ways to be poised to make your case for rates and contract terms that will help you better serve your community. Having assisted 10-plus providers through contracting and implementation, the presenter will share the steps providers can take to prepare for renegotiation and some of the challenges you may face. I'll now turn the webinar over to Cindy.
Good morning, everyone. Thank you for joining us today, and thank you for the great introduction and to PHCA for having me. I really appreciate the opportunity to talk with all of you. A little bit about myself. I had worked with the Department of Human Services for 22 years when long-term care was all fee-for-service. I did work through the introduction of health choices itself, which was quite the endeavor. And of course, community health choices is now, I can't even believe it, coming to the end of the initial period for the Southwest. When I had first thought about this, I was working on another project related to managed care in about February, and I was thinking about, this time period, renegotiation, or at least the time period when the rates will be up for discussion was fast approaching, and I was thinking about all the things that worked the first time around and all the things that did not necessarily work the first time around. And of course, all of you would have a lot more knowledge of what is working on the ground, what is working for you process-wise, and with regard to interactions with the community health choices, managed care organizations. So while I was thinking about those sort of ups and downs, I was thinking about, what's going to look different. And then, as you all know, COVID struck. So a lot of things are now looking different. And, for the safety of residents, for the safety of staff, for the ability to continue with your business, I think we all have to roll into everything that we're talking about or thinking about COVID, what that looks like and what that may mean long term. And additionally, I think this was a real bonk on the head for the plans and for providers in terms of some a large pandemic of this nature and what that means for business. Some of the things to think about with regard to COVID go, of course, from the feds all the way down to state government and, of course, impact your business. And as we go through and talk through the terms, that will be definitely a theme in terms of what does that mean for supports coordination? What does that mean for staffing? Can you get help with supplies? What does that mean for this contract? A couple of themes that I was thinking about throughout creating these slides are, the Commonwealth's position in all this. They've taken a hands-off approach because right now they're more the conduit for the funds, and the CHC-MCOs really are to manage the program. It does raise some concerns about accountability, because when you have concerns about what's happening with the MCOs, what's your ability to appeal, and overall the appeals just go internally to the Community Health Choices managed care organizations. So there's not a lot of great opportunity to challenge these organizations, but there is when you're looking to renegotiate. And the biggest thing I think that nursing facilities, long-term care providers have on their side is numbers. I mean, there are a lot of providers because there are a lot of folks to take care of, and PHCA is invaluable in helping to get the word out, but also helping you look at the various issues that affect all providers, because there's strength in numbers. And it's one thing if one small provider brings an issue before the managed care organizations, but it's different if a lot of varied providers are thinking about the same issues. So think about that. On this slide, you'll see some of the things that we talked about a couple of years ago for those of you that have ever talked with me about negotiations. And one of the important things is, yes, you want to clarify lots of things about the contract, but it's very important to look at the information, talk to an individual who has the ability to make some decisions, and also to pick your battles. There's some good information right on this slide about information that you can receive regarding provider services, etc. Likely most of you are familiar with this, and there's great information at the end of the slide too regarding the Department of Human Services and some of the links that they have as well. Here are the three major managed care organizations, and of course, Southeast, AmeriHealth Caritas' affiliate. One of the things to think about is that the department selected these managed care organizations, but you always have to go back to the contract with the Commonwealth. One of the things in working with providers throughout this process that I've noted is sometimes the language in the contract or the MCO's actual behavior does not match what is in the overarching contract with DHS. And I'll talk about a few examples, but it's important to familiarize yourself with the promise that was made to DHS, and that we all take the time to keep the managed care organizations accountable for those promises. These are some obvious tips. The biggest one is reach out now. If you have a very good contact at any of the managed care organizations, reach out to those contacts. Some of the folks that I worked with providers were statewide. Others were very localized. So start with who you've been working with, and if you don't have good contacts, reach out to either PHCA or myself to talk with the managed care organizations about who the best person might be for the varied issues that you may have. My understanding is that one of the managed care organizations are currently taking calls and talking to folks about potential rate changes coming up But again, remember, these are your contracts. It's a good opportunity to raise other issues and concerns that you may have and potentially have the opportunity to renegotiate some terms. Consider other issues beyond rates that either may affect costs or your programs or the service that you're providing to your residents. This is important for any kind of contract negotiations. Do your due diligence. Know the market in your area. What makes you in particular competitive? Understand the provider network. Is there any possibility, and I've heard no buzz about this, but is there any possibility that there may be a narrowing of the network, and what might that mean for you as a provider? Or is that not necessarily a concern in your area because of the care you provide? Document your actual costs. That's very important. I think in the negotiations the first time around, providers really discovered some hidden costs that were not necessarily covered or reimbursed. And then when the rate was a very specific rate, that became problematic moving forward. So document your actual costs so you know how that will work out for you. And be able to demonstrate your value and your differences. We're going to talk a little bit about quality measures and quality factors. Think about what quality measures are you working toward, either with other initiatives or internally. What kind of data collection do you have? What does that look like? Because I think that will drive how the managed care organizations do their process, do their program over time, because that is ultimately the goal, to be able to provide the best program at the least cost. And what kind of cost savings have you been able to implement that you can share with them? Are there any changes that the managed care organization may want? Are there any processes that are not necessarily working for them? In particular, I know that recently they have asked for electronic medical records information so that supports coordinators and I assume other parts of their business can have access to data more easily during these crazy times, which is understandable and reasonable, but we will walk through and talk a little bit about the concerns about those data releases and what you can do to protect yourself. And again, pick your battles. I already had mentioned that it's important to set up the meeting quickly and to get the right people at the table, and that they need to know the specifics of your organization. Be sure that the rates are set forth specifically. Do you understand the methodology? Do you understand what has gone into creating your rate? Although it seemed to be what we ended up with the first time around, except for a couple negotiations, one size does not necessarily fit all, and I think that should be a message that whether you're a smaller provider or a larger multi-facility provider, that we share with the managed care organizations, both for programmatic concerns and for rate setting. Again, back to the theme of the state's hands-off type of stance. OLTL really is there for guidance. They still provide meetings and have committees and talk with both providers and the managed care organizations, but they really only approve certain sections of the contract with providers. And the managed care organizations definitely have some leeway for negotiation, meaning that you also have some leeway for negotiation, as OLTL does not really get involved, certainly the way they used to, or DHS used to, in terms of fee-for-service. These are some general contract concerns. Generally speaking, the contracts and the addendums that are signed are evergreen. They don't necessarily need a new renewal sheets, but this is the time during the rate setting that you will be able to renegotiate. And either party is able to offer certain amendments and ask for amendments to the contract itself. There is, of course, on the MCO side, an interest in keeping these contracts as uniform as possible. So again, that goes back to the concept of it's good to speak with one voice. What's not working for the majority of providers, and where would we like to see changes? One specific question that I received from a client in anticipation of talking with all of you today is there a chance that the MCOs may narrow their networks? I would pose that question directly to them, and I have, and so far the answer has been no, there's not been any indication of an interest in narrowing the network, but they are collecting data about cost, and they are formulating their measures and what they're going to look at in the future to assure quality access. And one of the things that they would be able to do is narrow a network. One of the things that has always been troubling is that the termination procedures that are actually in the managed care contracts don't really set forth what's required in the DHS contract. So if you look at the second part of this slide, the CHC-MCO, there's a process that they have to go through in terms of notifying the department, having a termination work plan, notifying a resident, and paying the provider for up to 60 days. Now, this has not happened to date, but this is one of those things, if this should occur, if anyone should get a notification, you do have some time and some leeway to talk through both the transition and make an objection with regard to any kind of termination. So don't just rely on the pure language of your contract itself. Zaina touched on the term of the CHC-MCOs, which is, two different things we're thinking about, the rates and the ability to change the rates. And the other thing is their relationship with the Commonwealth. And the Commonwealth has structured this so that all of the contracts will end in 2023. However, DHS may extend their contracts for 2 years if it seems to be working reasonably. It seems like that may be a reasonable tack for them, given the expense and sort of the disruption that takes place when there is a brand new bidder and contractor. So just keep those time frames in mind, and we'll be relooking at this in 2023. Going back to possible termination of a provider, be sure that you ask, as you're renegotiating contracts, what are the standards for that termination? I have not seen anything that really sets forth any good standards, and I think it's beholden on the MCOs, if they are ever considering terminating a provider, to have a set of criteria that everyone can be aware of should that occur. Again, I talked about the appeal of the decision not to contract is only to each MCO provider appeal committee. This comes right from an FAQ by DHS and also from the contract itself. In that FAQ, going back to what I was saying about that hands-off, DHS specifically says this process does not involve DHS, so there's no ability to go to the Bureau of Hearings and Appeals like there used to be for fee-for-service kind of issues and cost report problems. Now, to touch briefly on something that is always on our minds recently, the managed care documents, the ones that I negotiated had a clear force majeure term in there. And a force majeure is when something big and bad happens, an act of God type of thing, like a pandemic, or another good example is, flooding at a facility where a party cannot meet their contract through no fault of their own. Then there's a forgiveness provision and a length of time to sort of cure the issues. I would recommend that in discussing contract terms, that language be added directly for some sort of global pandemic. I don't know that I should say, if any of you have had problems meeting your side of the contract with the managed care organizations, and part of it may have been related to COVID, this sort of force majeure term is something that you can rely on to get a little bit of leniency. On the other side, the same thing. It usually goes two ways, and the managed care organization is also able to rely on that term. But moving forward, I think it's something we should consider being more specific about protections and maybe added buy-in from the MCOs related to helping residents and helping staff who are affected by the COVID-19 pandemic. One other thing to think about is telemed. Is your facility using telemed? How is that working? Is that being reimbursed adequately? It may be good to have an added assurance in the contract that if the waiver, right now there's a waiver for telemed for payment that in effect requires payment to be on par really with other type of services that are provided in person. It also waives other things like services across the state. But in any event, it may be good that in the event that waiver stays in place after the federal emergency is lifted, that the managed care organization is still required to pay for those kind of services, because that's really a cost-cutting measure when it works for both the facility and the managed care organizations. I'm in no way saying telemed should replace visits and the ability to see a resident, but oftentimes it really allows providers, your doctors and therapists, a little bit of leeway and the ability to see more folks. Working with support coordinators, again, the sharing of data and information. Hopefully we'll get to a point where supports coordinators will be able to have full reign and visitation with the folks that they serve. But think about what practically might be helpful in a contract to talk about that processes. And if it's not in the contract, what process or what input can you provide to the managed care organizations to put in their manual? And finally, PPE support. I'm a firm believer that, it's an all hands on deck right now. And wouldn't it be great if there was donations of PPE or reimbursement for PPE so that some of the expense can be shared across both health plan and provider? And I know there is some of that, but from what I've heard from providers, it's definitely not enough. Some of the things to think about with the data connections for support coordinators and others potentially in the managed care organization is assurances that their connections are secure, both at rest and in transit. Is everything encrypted the way it's required to be? And during this work from home time, is there an assurance that the managed care organization supports coordinators, whether they be contractors or employees, have secure systems at their workplace? Additionally, I think it takes there should be a long look again at liability for data compromises, and certainly a user agreement that talks about authentication, getting into the system, tracking who is in the system, who does that, what does that look like, and of course, a minimum necessary standard. The supports coordinator shouldn't be able to go in and look at all of your residents. It should be certainly only those people that they in particular are serving. And how is that working? Is that working with firewalls? Are they able to create a system where they are not able to look at your full population, but only at their individuals in particular? We had, at the initial stage of contract negotiations, I spent a lot of time talking with the MCOs about some of the language in the contracts that were more strident at times than the actual regulatory language. Over time, the managed care organizations documents did track the statutes and the regulations very well ultimately. But if there are new terms that are added to the agreements, think through the second part of this slide. Are these more strident than the actual legal requirements? Are they actually your responsibility? Can you control what is happening in that provision? And that's an overarching concept. Never agree to anything that you have actually no control over. That's part of the whole idea of splitting the risk and being very careful about where liability falls. Another thing to think about is right now some processes with COVID have changed. For example, HIPAA provisions are less stringent in terms of sharing information with individuals who may potentially be infected and caregivers. But that may change. So that's something to watch as you're moving forward, and that's something to consider in terms of contract language. And some of these processes may stay in place depending on what the world looks like after a vaccine or the virus is not as rampant as it is right now. This is another term directly from the DHS contract. The MCOs are required to collaborate with the AAAs, including mental health, intellectual disability, and substance abuse. I have heard from clients that this does not always occur. There's not always great interface for behavioral health issues. And I think it's important to push the MCOs to meet this responsibility. I can't tell you the number of times over the last year where there's been a placement and the person is very hard, very difficult because of behavioral reasons to work with, and staff is put in a difficult situation. It takes a long time to straighten out. And it's important that the MCOs follow this contractual language and have skin in the game when it comes to these particular types of residents/participants. We're going to talk a little bit more about some of these concepts: rate negotiation, quality standards, and other miscellaneous but important terms. In particular, with regard to quality standards, hospitalizations, that's a very obvious one. But other than that, I haven't heard about the MCOs having a lot of metrics that they are actually using and working with to date. So that doesn't mean they're not out there. That doesn't mean they're not working through that. But it would be good for providers to understand what metrics they're actually looking at sooner rather than later. Again, this is some language directly from the CHC-MCO's contract with the state. They may include provisions allowing for when rates will be negotiated. That's pretty obvious right now. I mean, with the time frame ending right now in the Southwest and the other regions to follow shortly thereafter. The language is not super helpful, and it's pretty vague in the contract. The CHC-MCOs have to develop a rate configuration that assures access, quality of life, and quality of care. But those are some things that you can think about in terms of in terms of access, for example. Where are you? Where are you located? Is your facility absolutely necessary for access for individuals in your area? What do you provide that maybe other providers in your area do not provide? Quality of life and quality of care. Quality of life has usually been one of those things that we think about. What does it look like at end of life? What are your hospice services? What type of care is provided toward the end of life? And quality of care, again, that's back to the metrics. It would be good to see what the MCOs are thinking about. And finally, if you're asked to do more, in the DHS FAQs, they recommend raising this in the contracting process, especially efforts that are raising costs such as COVID-19. Again, the CHC, they can consider all of these things that are, directly outlined, but we haven't seen them come out with clear criteria related to quality outcomes and incentives. Those are outlined a little bit better in the contract between the state and Community Health Choices, but these are things that you can think of in terms of what's happening with your hospital admissions. What kind of quality outcomes are you looking at? Are you tracking? Are you doing that? Should you be doing that? Population metrics really will be how the managed care organizations sort of look at their costs and control things going forward. So the quicker that you as a provider have a handle on how to gather that metrics, look at that metrics for yourselves, the better it will be, the better negotiation position that you'll be in. Any type of incentives, when the managed care program, Community Health Choices, was first being put in place, there was a lot of discussion about potential incentives for various programs. Have any of them come to pass? And we'll talk a little bit about the language of the DHS contracts that requires them to work on some of these things. And again, your complex residents, your unique circumstances, what kind of services do you provide above and beyond what may be just standard nursing facility level care for some of your complex individuals? Here, this language is directly from the contract. CHEs have to demonstrate that the rates account for increased costs as a result of mandates on staffing, wages, related cost drives. I think there would be an argument on the other side that mandates only means a regulatory or legal mandates, but I would argue that's not accurate, that staffing, wages, other cost drives have been mandated to increase based on what is happening with COVID. And it actually says high-cost participants. So again, back to very clearly looking at your costs for providing actual services. There's been a lot of discussion about transportation, and initially in the Southwest, we had some negotiations, and there was an extra bump related to some transportation that SNFs were actually providing. The history of it is that the managed care organizations then discovered and talked with OLTL and indicated that this was not actually in their capitation rate, and they held firm to not adding additional monies related to transportation. That said, again, this is one of those actual costs that sometimes exceeds what you might think and what certainly their per diems are covering. But this is the language directly from the contract. The CHC-MCO must provide all medically necessary emergency ambulance transportation and medically necessary non-emergency ambulance transportation. Now, I understand that that is not always happening with all of the MCOs. So if you're actually having that issue, I encourage you to look at the contract with the state and raise this issue. I was talking with Gail Weidman in preparation for today about some of the things PHCA has been thinking about. And one of the things that she had raised, and she said she has been raising, is that the MCOs consider a waiver process similar to the process that's undertaken both by the state and the feds, where you submit justification for a potential waiver of a requirement or a regulation. And one thing that she was suggesting is with regard to the occupancy requirement, therapy leave days, with census being low, it's difficult because there are above and beyond the 30 days that are at issue. So consider raising, and I know that PHCA is in your corner on this issue, waivers, but consider this process for other things too, and encouraging the MCOs to waive certain provisions during this difficult time, because it really seems like a well understood mechanism in government, and they are in effect administering a government program. So there does not seem to be a reason why they, like federal, state agencies, county agencies, and their contractors, are not able to think about the same process. These are other issues that I would recommend that you clarify with the MCOs. What is happening? There seems to be problems with 180-day claims and not a clear process either across MCOs or necessarily in each of the MCOs. And prior medical expense deductions. And again, I touched upon behavioral health. I think I mentioned before, Gail Weidman and I are working on a checklist. We had initially done a checklist for contract negotiations for the managed care organizations, but we're revising that. The good news is that a lot of provisions in that checklist we're taking out of there because it seems to have been settled over time in the contracting process, but then we're adding some new ones, of course. But we will be sending that out. PHCA will be sending that out to all members, and we'll be sending that out to this group separately. So I'll talk a little bit more about that in a bit too. Again, this goes back to, as an industry, it would be good if long-term care providers, nursing facilities in particular, were able to stand together to discuss some of the quality and pay-for-performance initiatives that would work for facilities and that would be realistic. We have to get a good sense, again, about what the CHC-MCOs are thinking about. And maybe they're not in a position right now, but I think, we're 3 years in. It is time to be thinking about looking at some of these metrics and how you as providers can benefit and potentially offer more programming for your folks with revenues that are saved or saved through quality or gained through a pay for performance type or value-based arrangements. In the CHC contract directly with the state, there are requirements, and to date, I think it's been difficult for the MCOs, given that they're dealing with COVID too, to sort of provide some of these things. One thought is that if you are already providing some of these services, such as classes, workshops related to health and wellness, education materials, consider, is there a way to be reimbursed for that, since the managed care organizations really are required to provide those services anyway. Some of these are prevention topics that are actually specifically listed in the department's FAQs, and I definitely know of providers that are already doing some of these things right now. They're working on heart attack and stroke prevention measures, exercise classes, looking at other chronic conditions, and again, back to collecting data for some of these individuals so that you can track successes. The CHC is required to have a decent referral process and use and manage the care of the participants. This is particularly important because we want to understand that this is actually happening, and again, also hold the MCOs to this requirement, because it's been my experience, and I've certainly heard, that this has been shifted really back to providers to be sure that individuals are referred appropriately. Should that look a little bit different? Should payment be a little bit different for these types of referrals and services? How have these processes been? In particular, abuse and neglect, what is happening, what is occurring with hospice and hospice providers. In both of these arenas, I have heard concerns raised by two providers. So I encourage you to think about that if you are raising issues with the managed care organization in the next couple months. I can never say this enough. We worked hard to try and take language out of the contract that incorporates the managed care organization manuals by reference. And what that means is that the manuals are actually thought of as part of the contract. The problem with that, and what is absolutely not cool from a provider perspective about that, is that you are required to comply with those provisions as if it was a contract. So it's always important to read changes, hold them to the fire in terms of providing those changes, and also providing meaningful feedback to the managed care organizations about those provisions. In several contracts that we worked on, we did get the ability per se to provide meaningful input, but you could at all times, of course, let them know if you have an objection or concerns about changes to incorporated materials. I touched on the community health choices provisions checklist that Gail and I are working on. These are some of the things that are in there. It's a chart, and it actually has narrative about each of these issues, and the document now, it's getting longer, but we're trying to make it manageable. But what it does, it has other areas of the document where you can check off who's responsible for taking care of these particular issues and looking at these particular issues, so that you can have a work group, if that's feasible for you, working through the contract and looking at concerns, so that you could go in an organized fashion to the managed care organizations with your concerns. Again, more right here, and we will be sending you all a copy of that checklist in the next couple of weeks, and I hope that's helpful for you. As you move forward, I'm sure many of you are doing this, and I've talked with providers in the past about developing tracking so that you always know what is happening with your residents, who is their provider at any given time, who are the good contact folks to be sure that they get the best services from both you and also the managed care organizations, and track your ancillary providers to be sure that they're still in network, so that any referral that you're doing will be covered, and that it will go quickly and the referral will go fast. And of course, work closely with case management and supports coordination. And of course, staying up to date. We've added a couple of great resources, in particular PHCA's website and DHS's website, and you can always reach out to me if you have questions, and I am happy to help. And thank you for your kind attention today. I appreciate it. Do we have any questions?
Yeah, thank you, Cindy, for sharing all this information today. It's been extremely helpful and informative. At this time, like Cindy said, we'll take questions. If you have any questions, you can submit them through the question box on the right-hand side of your screen in the GoToWebinar pane. All right, so we have some questions coming in now. So first question for you, Cindy. If the state is not increasing funding to the long-term care line item, how are providers going to seek an increase in the rates from the MCOs?
That's a great question, and that probably will be what you hear from the managed care organizations. And they are, my understanding, financially strained. But I think part of the issue is that going back to those quality measures. Are there ways to show that there are cost savings that you're doing and that you can request some of that? And additionally, some of their cost contractions, their ability to contract costs where they are, especially where they are using your EMR, collecting data from your EMR, necessarily using less of their staff and streamlining their processes. Moving forward, I think it's beholden on them to figure out a way to be more efficient so that actual costs can be met and that the providers are not strangled. Again, it is a hard issue. It's very difficult in terms of the financial setting right now. But I do think that it's important to be realistic about what providers need moving forward, and that may help them additionally be able to lobby moving forward for an increase in funding for themselves, maybe not on a budget line item this fiscal year, but next fiscal year.
All right, next question for you, Cindy. Do we know if they plan capitation rates will change in the upcoming year?
I haven't heard a commitment. And if I do, I will definitely, PHCA and I will have a conversation about that. But PHCA actually, Gail Weidman again, keeps her finger on the pulse of all this too. So I think when we know, we'll know.
Any other questions for Cindy?
I'll put up my contact info. Ooh, I'm sorry to have put my picture on there, but in any event, my contact info is there. I'm always happy to take questions if you would like to talk directly.
Any other questions before we let you guys go and get a few minutes back in your day? All right, seeing none, thank you again, Cindy, for all the information today. For the attendees, please stay on to complete the survey. Today's webinar recording will be made available on the PHCA website, and be on the lookout for more scheduled PHCA webinars and events in the future, particularly the Unconventional 2020 PHCA Convention registration, which is now open, and more information will be shared with you in the coming days. Thanks again to Cindy, and have a great remainder of your day, everyone, and stay safe.
Thank you, everyone.